Hello, and welcome to another edition of Cancer Speak. I'm your host, Dr. Suresh Ramalingam, Editor-in-Chief of Cancer and Executive Director of the Winship Cancer Institute of Emory University. Today, we're recapping highlights from the 2025 annual meeting of the American Society of Clinical Oncology. This meeting brought together the oncology community from across the world to share meaningful advances in cancer research and care. I'm joined by two members of the cancer editorial team who attended the ASCO 2025 meeting in person. In addition, we also have a patient advocate joining us for this conversation. First, we will have Dr. Gil Morgan, one of our social media editors. Gil, welcome back to Cancer Speak.
Thank you so very much for this kind introduction, the kind invitation, Ram. It's truly a pleasure to be here with you, with Allison and Sandip, to discuss everything that happened in ASCO 25. So to all of our colleagues tuning in, my name is Gil Morgan. I'm a clinical oncologist by training, and I'm a representative of the OncoAlert Network. And this is an NGO dedicated on amplifying reliable oncology information for professionals and developing educational initiatives to support the oncology community. I'm also incredibly proud to serve as a social media editor for cancer and to be a part of this outstanding team.
I would like to mention to our listeners that OncoAlert is an official partner of the American Cancer Society journals, including Cancer. Next, we're thrilled to welcome Dr. Sandip Patel, who serves as our section editor for developmental therapeutics and is also a social media editor for Cancer. Sandip was named a fellow of the American Society of Clinical Oncology this year. Congratulations on this well-deserved honor, Sandip, and welcome to this podcast.
Great to be joining you, Gil, and Allison to really be discussing all that's been happening in oncology. And we got to get together once a year at ASCO and many other conferences to celebrate all the advances we made, but also think about all the things we have to do to help patients. In my role, I'm here at UC San Diego Moores Cancer Center. I'm a professor in medicine and a deputy director of our Sanford Stem Cell Clinical Institute and medical director of clinical research informatics. So great to be joining. I think for this group, my role as section editor for developmental therapeutics, there was just so much at ASCO going on in developmental therapeutics and artificial intelligence. Excited to be joining you guys to talk about it today.
Last but not the least, we're joined by Allison Rosen, who is a colorectal cancer survivor and longtime patient advocate. She also attended the ASCO 2025 meeting. Allison, it's great to have you join us.
Thank you so much for having me and letting me lend my voice from the patient survivor perspective. I'm a 13-year colorectal cancer survivor, and I think this was my fourth ASCO attending as a patient advocate, and it's always exciting to learn from leading experts in the field. And I was excited, and I'll talk about it a little bit later, about how the patient voice was incorporated a lot in the annual meeting this year. So just again, excited to be a part of the conversation, and thanks for including the patient voice.
Gil, let's start with you. Through your work with OncoAlert, you have a unique perspective on the breadth of research presented at ASCO. From what you tracked and followed during the meeting, give us some of the major highlights as you interpreted the results of the key research presented at the meeting.
Thank you very much, Ram. And what an exciting time we had in Chicago. When we talk about the biggest news coming out of ASCO 25, I have to say that in my opinion, breast cancer absolutely stole the spotlight. There were 5 standout trials, 3 of which were published concurrently in the New England, which really kind of underscores their impact. So let me walk you through each one of these, what was tested, why they matter, and what the overarching message were. So the first major one was the VERITAC-2 study, and this was featuring bevdegastrant, a PROTAC estrogen receptor degrader. It was compared head-to-head with fulvestrant in patients with ER-positive, HER2-negative advanced breast cancer, all of whom had already been treated with CDK4/6 inhibitors and endocrine therapy. Now, the key takeaway here is that the subgroup of patients with ESR1 mutations, for them, bevdegastrant more than doubled progression-free survival compared to fulvestrant, 5 versus 2.1 months. And that's a meaningful difference. In the overall population, however, the results did not reach statistical significance. So the benefit seems really confined to the ESR1 mutant group. But this trial tells us that precision targeting, even within ER-positive disease, matters. Bevdegastrant could very well be the next big thing for this specific patient population. Now, next, we have the INAVO120 trial. This was the first phase 3 trial to show an overall survival benefit with a PI3K inhibitor in breast cancer. Inavolisib, when added to palbociclib and fulvestrant, improved median OS from 27 months to 34 months in patients with PIK3CA mutated, HR-positive, HER2-negative advanced breast cancer. Now that's huge. Objective response rates more than double while toxicity was higher, especially hypoglycemia and mucosal side effects. This was still a win. The big message here was, yes, you can add targeted therapies like PI3K inhibitors and improve survival, not just PFS, in endocrine-resistant breast cancer. Another study was SERENA-6, and it was a brilliant use of circulating tumor DNA. Patients with ER-positive, HER2-negative advanced disease on an aromatase inhibitors plus CDK4/6 were switched to camizestrant, a next-generation oral SERD, as soon as an ESR1 mutation was detected in their blood. This was before clinical progression, and it worked. PFS jumped from 9.2 months to 16 months. That's a striking result showing how real-time molecular monitoring can guide us before we see disease progression on scan. The overarching message: we're moving into an era of proactive rather than reactive treatment in breast cancer. And we had two more standout trials. First, the ASCENT-04 trial, or Keynote D19, where sacituzumab govitecan plus pembrolizumab was tested against standard chemo plus pembro in patients with PD-L1 positive, untreated metastatic triple-negative breast cancer. The SG combo significantly improved progression-free survival and response durability, and it had a manageable safety profile. This could mark a paradigm shift, moving away from chemotherapy in the first-line setting for triple-negative breast cancer towards ADC-IO combinations. And finally, the DESTINY-Breast09 trial, where trastuzumab deruxtecan plus pertuzumab was tested head-to-head with the current THP regimen, taxane, trastuzumab, and pertuzumab in HER2-positive advanced breast cancer. TDXD plus pertuzumab nearly half the risk of progression, with a median duration of response exceeding 3 years. While OS data are still immature, this could very well become the new first-line standard for HER2-positive disease. And those are just my 5 personal top picks from ASCO 25.
These are very exciting results, have clear impact for patients with breast cancer. To see 5 different approaches make clinically meaningful impacts for patients is very exciting at the same meeting. It just shows the pace at which oncology research and how it impacts care is advancing so fast. Now, let's turn our attention to a session that Sandip chaired. Sandip, you chaired and presented on accelerating clinical trials with artificial intelligence. Tell us about that session and what you see as the implications for future.
No, Ram, it's a great question. Artificial intelligence was one of the probably hottest thematic areas at ASCO 2025, including plenary presentation about a collaboration with Google around taking the ASCO guidelines, putting them through a RAG, which is a type of language model, so you can actually interact with the guidelines and ask questions of it. And so with that as the start of the meeting, many of the AI themes permeated throughout the clinical trials that were presented. Our session had wonderful input from both Friends of Cancer Research as well as the FDA. So really looking at how multiple organizations, both academic medical centers, nonprofits that support research, and then regulatory bodies that supervise and have regulatory authority over research, look at artificial intelligence. It's a very rapidly evolving area. I think many of us utilize artificial intelligence in our day-to-day lives and increasingly in our clinical lives. And so the question was, for our session, how do we ensure that clinical trials utilize artificial intelligence safely? We're already testing an investigational agent. And so to add an investigational algorithm, either for digital pathology prediction of which patient may respond to treatment or not, for radiomic assessment of a patient's response through AI augmented RECIST criteria, for example, or how to use artificial intelligence models to decrease the burden of reporting in clinical trials. For example, taking information directly from the electronic medical record into the electronic data capture systems for sponsors. These are some of the topics that were discussed. Some of the high-level themes included some of the consortium-level projects, because with artificial intelligence, often the model is only as good as the N in terms of the data inputs that are in there. And so one area of interest, and Gil alluded to this earlier in terms of breast oncology, is this concept around HER2 low. And when you have a very low expression of a biomarker, there's a wide variance in how pathologists will call this entity of HER2 low. And so the use of artificial intelligence, and specifically digital pathology, to standardize what is classified as HER2 low was presented. This is a project led by Friends of Cancer Research, who were trying to standardize this across multiple HER2 low targeting clinical trials. And they showed that with artificial intelligence-based methods, with digital pathology, you could increase reliability. The receiver operating characteristics were very robust. And so I do think that when we look at digital pathology, this is one of the areas that we can help pathologists and improve standardization, and thus make sure that when we have patients on clinical trial, it's a more homogeneous population. We're not introducing extra variability based on our ability to call that type of biomarker. The other area that was very much of interest was around the regulatory path for these algorithms. As many have utilized AI in their life, there are different versions, right? You go from ChatGPT 3 to 3.5 to 4. You may go from Gemini Pro to the next version, Premium, for example. How robust is that transition, right? These algorithms vary. And if you go from version 1.0 to version 1.5 to version 2.0 of an algorithm, what does that process look like? What evidence do you need to generate? So there was a very nice talk by the FDA about their perspective on using artificial intelligence in clinical trials, but also now increasingly, as many have heard, in the review process for the assessment of clinical trials. And in fact, something that struck me was that in CEDAR, which is one of the main areas for submissions to the FDA, over half of submissions from oncology utilized artificial intelligence and almost a third in CBER. And so oncology is leading the way in terms of artificial intelligence for clinical trials, not only in terms of pathologic assessment, trying to find the right patient for the right study and try to match that patient to the study they'll do best on, not only assessment of that patient by trying to standardize RECIST criteria, but also when the trial is all said and done, the actual submission to the FDA to try to make sure that drug is available to patients in the standard of care setting as quickly as possible. And so I think this is the tip of the iceberg, and I have a feeling we're going to be hearing more about this at future ASCOs as well as in our journal.
These are transformational steps towards changing how we conduct clinical trials and how we learn from clinical trials. My hope is that these will make it easier for A, patients to participate in clinical trials, and B, for investigators to conduct clinical trials. And it sounds like what you're describing gets us a little closer to that. Is that a fair statement?
Absolutely, Rob. I think, as you've mentioned, the number of assessments for clinical trials has exploded, and the ability for us to do this manually is really limited. And so artificial intelligence approaches to decrease the friction on those reproducible pain points, the part of your job that is maybe more frustrating to do. I think it's low-hanging fruit for AI assistance. I think, for example, in clinic, that wasn't part of our session, but a different session and also a theme throughout ASCO was use of AI scribes in clinic, where you turn on the phone or turn on the mic and the LLM listens to your conversation with the patient and then transcribes a note. And some versions are actually going to suggest and penned orders for you in the future. And the beauty of that, and I utilize this in my clinic, is I am just focused on the patient. I'm not sitting there in front of a computer. I'm not typing. And so you can imagine, as we decrease the burden on those tasks that distract us from that human to human interaction by relying on computers, we can really lean into those skills that I think our patients are most interested in getting from us, given the amount of time we have for a patient. I think the amount of eye contact that we can increase by utilizing these artificial intelligence tools to get rid of the amount of eye contact we put on the screen can only help us. And that's true of clinical research as well.
Very eager to learn how this evolves in the upcoming months and years. Allison, I would love to hear from you about your perspectives on what stood out most for you at ASCO. What conversations or moments left the biggest impact from your perspective as a patient advocate and survivor?
And I will start with the AI piece. I had a line in some of my notes. Most of the AI sessions were standing room only. And as a patient survivor and very, very passionate advocate, I've told other people that are getting diagnosed, especially that are looking for clinical trials, that we have to have some trust. This technology is not going anywhere and it could benefit them, because often people ask me, Allison, what is the best trial I should do for, this specific mutation I have or this type of cancer I have? And I can help navigate a little bit, but using AI tools, it can look all over everywhere, and it can give them a much more comprehensive list of potential trials that they can then go and do their research on top of what I can provide as a human. And so I think AI is great. I didn't get a seat in one of the sessions. I was standing the whole time because it was so people want more information about it. So I think as a patient, I think it's having providers explain the tools and say it isn't replacing them. It's just helping to supplement what they're doing as far as treatment is concerned. That was one key takeaway, because that was for sure, those sessions were very, very well attended, and there was a lot of really interesting information. And then another one that I found most interesting that I still hear people talking about, was the challenge study, where structured exercise program after adjuvant therapy involving fitness, PROs, overall survival, all of that showed increased overall survival, increased quality of life. And so I think there's been a lot of studies about what we can do to prevent cancer, but then also as a survivor, what we can do to prevent recurrence and so on and so forth. before. So when we heard a lot of information about this challenge trial, and it showed some of the information that I got out of it, which was great. Again, and I brought that back to the community that I serve and people that couldn't be at ASCO that are going through treatment, is that for every 14 people, exercise prevented one person from dying. I mean, and that's huge. That was huge. That was a great fact. That was great information. And that's digestible for me to take back to my community and tell them about. So I've heard from people that I work with as an advocate, oncologist, and people in the field that hopefully some sort of structured exercise program can be a part of survivorship care plans and or treatment that when they're talking to their patients. So that was something that was eye-opening for me. And then also in a plenary, a statement that really resonated for me as a patient was that PFS doesn't automatically mean quality of life. And so I think that patients care about quality of life so much and overall survival, but progression-free isn't necessarily the most important thing to them, especially with the rise in early onset cancers. And there was a big theme at ASCO talking about early onset cancers and what is the state of the science of that. I really enjoyed that session because there's a lot more research and a lot more funding going into figuring out the why. We know it's happening. You know, again, as an early onset colorectal cancer survivor, why did I get it? We don't know yet. But ultimately, having a lot of focus at this huge annual meeting on early onset, not just colorectal, breast, lung, all these other cancers that's happening in younger people, is going to help create more research, more interest, with more funding, more research as to figure out the why and if there's anything we can do to prevent that from happening. So those were some things that really stood out to me. The early onset piece, the survivorship piece of exercise, and again, incorporating patients and survivors in the panels. So I went to so many more sessions this year than I had previous years that they had a patient advocate, survivor, or patient providing their perspective, because I think that's so important to not only remind the audience of who they're treating, but also put a human face and voice to what we as patients and survivors go through every day.
Thank you, Allison. Your point about not just efficacy, but impact on patient quality of life as a key factor when physicians and care teams make decisions for patients along with patients resonates very well with me, and I'm sure will do with our audience as well. Pace of progress overall, as we can see from ASCO, is staggering. My early days as an oncologist, when I come back from ASCO, I could probably count with one hand the number of practice-changing trials that were presented across the meeting. Now, for every disease track, there are so many. Just in the past 3 months, there were 4 new drugs with new indications approved for lung cancer alone by the US FDA. So, Gil, I want to ask you, how do people keep up? You talk to a lot of oncologists over the world. How do we make sure everyone is updated on these exciting progress that's incorporated into practice?
That's a great question, Ram. And I think we're doing it right here. So by podcasts like the one we're having now, by being present, I'm a big advocate for social media, especially X, LinkedIn, but quite honestly, any platform that we as professionals feel comfortable with, or any cancer stakeholder wants to share that message of all these new developments that are happening within cancer. I think it's very important that we just overcome our shyness and just share away, because the more that we share, the more we amplify and the more people that we're actually able to reach. So I think it's a very exciting time, not only in the amount of new therapies that are coming out, but the way that we're sharing the development of these therapies and all of the news that are coming around these therapies.
Allison, what are some of the ways patients are learning about these from besides their care teams themselves?
I mean, I think Gil said it exactly right. A lot of it's through social media. So I'm involved in a lot of different advocacy organizations. So I share on X, but then we have a lot of groups that are online on Facebook and or Instagram. And we have our own sort of podcast where we share. There was an ASCO recap that Fight Colorectal Cancer did. I know that CCA was tweeting away, but ultimately there's a group of us advocates that attend these meetings regularly. And then we take the information back to the people that we work with and into the community, because everything I learn about, especially new treatments. When someone's like, oh, if the standard of care changed for a specific stage of cancer, I blast that on my social media. And I luckily have a following so that can get out to the people that aren't able to attend the meeting. So I think the presence of patient advocates at these meetings is so important, because we can take the information that might not be so digestible to the average person and digest it and talk about it on social media to make sure the right people are hearing it. Because you get people that are in rural areas that might have no idea that immunotherapy therapy is an option for them over standard chemotherapy. And it gives them an option to take that question back to their provider. So really, my role that I see at these meetings is to take the information, digest it, and translate it in a way that people can understand it and get it out as far and wide as I can. And I share that on Instagram, Twitter, but also on TikTok, which, might be taboo to say, but there's thousands and thousands of people on TikTok. And I talk often about colorectal cancer screening, clinical trials, access. And the way you're going to create access to this stuff is to spread that information as far and wide as you can. And I think social media is one of the best platforms that I use besides having one-on-one conversations with people that know I'm going to these meetings. I also ask ahead of time on my social media platforms what are some questions they have and ask people at the meeting if they're presenting on a specific topic.
As we wrap up this conversation, maybe we can get some quick thoughts on what are you excited about the future? What are some things that you're looking for as potentially shaping the field of cancer? So we'll start with you, Sandip.
Yeah, I think it's a great question. I think continuing the theme of artificial intelligence, I think in some ways it's overhyped in terms of what we could do today, but the long-term promise of AI improving the patient experience, improving the clinician's experience, improving the conduct of clinical trials, helping us better define subtle subsets in studies, either through better biomarker assessment or use of radiomics. We talked about efficacy prediction. What about toxicities, right? And so I think that we're really just seeing the tip of the iceberg. Artificial intelligence is kind of like the internet. It's a tool. It's here to stay. And it's how we use it, right? Responsibly can be used irresponsibly as well. But the responsible use of artificial intelligence will really raise the bar, I think, for cancer care delivery. And I think all of us are playing an important role in our individual lanes on advocating for the responsible use of these tools to make sure they benefit patients, because they're a double-edged sword. If they're not utilized well, they're not utilized appropriately, or they're utilized even haphazardly, they can lead us down the wrong pipe.
Allison, your thoughts?
Yeah, I think that this meeting and the ones that I've been to over the past year, I think the advancements in prevention, surveillance, and survivorship really excite me. But then also the treatments that are available for advanced cancers, because I have friends that are stage 4. Again, I've been an advocate for 13 years. At one point when they were diagnosed with stage 4 breast, colorectal, lung, the overall survival was very low. Now going to these meetings and seeing the advancement in the type of treatment and how much longer they can live and survive later stages is huge for me and is really exciting. So I hope to continue attending and listening and hearing about more treatment that, again, less toxicities, overall survival better. And ultimately, I want to be able to say one day that stage 4 is not a death sentence, because I don't think it is. And I think meetings like this have proven that as research continues, it won't be.
Gil?
I think that ASCO 25 or after ASCO 25, we're filled with hope and lots of promise. So we know that precision medicine is here to stay and it's evolving fast, whether we're targeting ESR1 or PIK3CA mutations, using real-time ctDNA to guide treatments, or combining ADCs with immunotherapy. We're seeing major leaps in the tailoring of care. And there are real survival benefits that are coming with this. So it's exciting times that we're living in, and I'm actually just very excited to see what is coming up next.
I really like the fact that you brought up the word hope, because these excitements give our patients more hope. A life free of cancer, or a life with cancer without cancer being terminal or determining their lifespan. This has been a wonderful discussion. I want to thank all of you for your expert insights, and I know that our listeners will appreciate the perspectives that you've shared. Before we close, I would like to remind our audience that cancer is always looking for high quality research submission. Our purpose is to bring the best of science to the broadest of the readership. We made it easier than ever to submit manuscripts with options like free format submission and direct to cancer. We'll include more information about these features in the show notes, and we encourage you to consider cancer as the home for your cutting-edge research. Thank you for listening, and we look forward to having you join us again for a future episode of Cancer Speak.